Hi, and welcome to another author interview. I'm Brian Jacobson, one of the associate editors for gastrointestinal endoscopy, and I'm here with Dr. Ali Siddiqui from Thomas Jefferson University, who's going to be speaking to us about his paper that was entitled Endoscopic Ultrasound Fine Needle Aspiration Cytology from Solid Pancreatic Cancers.
Thank you, Brian.
So first, Dr. Siddiqui, tell us a little bit about what prompted you to study this.
What's very interesting, endoscopic ultrasound is really behind the modality of choice to diagnose pancreatic lesions. And there's a recent paper published in Gut by Gleason et al., which, to our surprise, indicated that the false positive rate for endoscopic ultrasound fine needle aspiration was 5.3%. Now, previously in the literature, it's been reported it is 0 to 1%. So that essentially interested me and prompted us to perform this study to see what the false positive rates were for endoscopic ultrasound FNA for solid pancreatic lesions.
And tell us a little bit about what did you find?
Well, essentially we undertook a retrospective study and we evaluated all the patients who we had performed EUS FNA on for solid pancreatic lesions. We included only those lesions who then went for a surgical resection because we use surgery as our gold standard for pathology. And what we found was that we had a total of 367 patients in our study, and 4 out of those 367 patients who were essentially diagnosed by EUS FNA cytological diagnosis were having a malignancy on cytology, were actually found to have chronic pancreatitis. So essentially those patients were diagnosed as false positive by cytology, and that was a false positive rate of 1.1%.
So these were all surgical specimens that went funnily?
Absolutely.
Okay. And then what would happen if they were labeled as suspicious? Did that change things?
Well, that did change. So we did do an analysis of suspicious cells, and if we include suspicious cells, then the false positive rate was actually 3.8%. But when we get a suspicious cytology, then it kind of puts us in a little bit of a quandrum about where we need to go from there. And when we get a suspicious cytology, then we have to use our clinical pretest probability to determine whether we really think that the patient does have a malignancy or whether we think that this is a false positive rate.
Right. And unlike perhaps taking out an appendix, just to be sure, having a Whipple procedure is a bigger undertaking.
Absolutely.
So I would think some of this is very cytologist dependent.
Absolutely.
Did you have other cytopathologists go back then and re-review?
We did. So the patients who were diagnosed as being false positive with cytology, we did a re-review by our cytologists, and they were blinded. And essentially, all patients that were diagnosed as being false positive on our initial cytology, when we did the re-review, they did note that that it was an overread, that patients actually did have atypical cells, but they could not call them as being positive for malignancy. And that's kind of changed our practice now at Jefferson, is that if there is a cytology specimen that is diagnosed as being positive for malignancy, that there has to be an agreement between 2 pathologists before they give the final diagnosis of being positive.
So an important internal check now.
Absolutely.
So it's changed how you practice.
And the other thing that we've reiterated also is very close communication between the gastroenterologist and the cytologist to tell the cytologist about the history that the patients present with, your pretest clinical suspicion of whether there is indeed a malignancy or not, whether you think it's autoimmune pancreatitis, chronic pancreatitis, or a malignancy.
So nothing in a vacuum. Great. All right. Well, do you plan to do this study again in other types of diseases?
Absolutely. I mean, what we would like to also do is now look at different EUS FNA cytologies for lymph nodes and for other type of malignancies, especially for lymph nodes, where if you look at Gleason's study, the majority of patients of theirs that were diagnosed as being false positive were actually patients who they did a final aspiration of the lymph nodes. And one of the things that it may have been in that case was they were actually, when they were performing the FNA, they were actually going through the wall of the primary tumor and then going into a lymph node.
Right. Okay. That's another very important caveat. All right, well, thank you very much
All right.
for spending time with us
Well,
today.
thank you for the opportunity to talk about my research.
Good.